morning everyone. Today we are going to learn about transesophageal echocardiography. So what is transesophageal echocardiography? It is an invasive form of echocardiography in which a specialized probe containing a ultrasound transducer which passed into the patient esophagus to image the heart at the various level. So why we are doing this transesophageal echo? So first of all, we know we have a very good image quality in the transthoracic echo, but some special information which we will get through the transesophageal echo because some of the structure are present in the posterior to the heart like the mitral valve, left atrial appendage, left atrial, which are better visualized in the transesophageal echocardiography. So for that pathological view we have done a transesophageal echo. So specific indication for the transesophageal echo, so the structure which are lie in the posterior to the heart, just like left atrial appendage, aorta, then other pathologies like prosthetic heart valve, paravalvular abscess, then during the perioperative procedure, then ASD device closure, BMV guidance for the septal puncture, and certain high procedure like mitra clip, transesophageal edge repair. So for the transesophageal echo, we have certain contraindication. If the patient has already had the gastric perforation or the gastric bleeding or the esophageal laceration perforation, then diverticulum or the oropharyngeal laceration or the perforation, that lead to the special contraindication, and other is that lead to the trauma, that lead to the perforation, laceration, and the false passage that lead to the via the transesophageal echo. So some special absolute contraindication for the transesophageal echo, that is in the esophageal. So in the esophageal stricture, tumor, any perforation, diverticulum or the active GI bleed, these are the absolute contraindication. Those patients who are presented with the upper GI bleeding, we have already absolute contraindication for the transesophageal echo. Certain relative contraindication like thrombocytopenia, septicemia, peptic ulcer disease, cervical arthritis, dysphagia, any Barrett esophagus, or the any recent history of upper GI bleed or the upper GI surgery. So these are the relative contraindication. So regarding the patient preparation, we have the patient preparation regarding that. So patient should be nail by mouth minimal 6 hours before the planned procedure, or the restraint of the all the intakes 3 hours before the procedure. So ensure that the adequate range of neck movement should be there, adequate mouth opening should be there. Then administration of the local anesthesia like lignocaine spray or the gargle we have to done for the crico muscles and the posterior wall of the pharyngeal muscles to relax. Then sedative agent like conscious sedation, we have to use midazolam, most commonly used agent nowadays. And in the difficult situation, sometimes reversal agent like flumazine or the naloxone should be available if needed to reverse the effect of these drugs. So we start with the transesophageal echo probe, which are connected to the our echo machine. So it containing from the distal tip, it is a transducer lens which produce the image, and then followed by the flexible shaft, that is gastroscope, and then transducer control. This transducer control, in the control housing, it contain two wheel, one is small and one is large wheel, which help in the movement of this transducer lens to the antroflex or the retroflex or toward the right and left direction, and then cable connector, and then controlling housing which connect to the echocardiography. Then these are the transesophageal echo probe. It contain the there is a two movement which are main important in thing. One is advancing the probe and another is withdrawing the probe. So gradually advancing the probe from the incisor teeth. So it is starting from the 20, 30, 40, 50 or 45 centimeters. So here after advancing and withdrawing the probe, you have to flex either anteriorly or the posteriorly. So anteriorly flex we call as a antiflex, and the posteriorly we call as a retroflex, and then turn toward the right, that is a clockwise and the anti-clockwise position. So according to that, we focused on the right side structure, we move toward the clockwise, and in the left side it called as anti-clockwise. Then here we can see there is a rotating movement on the electrically movement is from 0 degree to 180 degree. So in the 0 to 180 degree, there is a we call as a horizontal plane, and in the vertical there is a 90 degree we call as a vertical plane image. So by this we have image at the certain level. So in the transesophageal echocardiography, there are the four main view which are described for upper esophageal view, mid-esophageal view, transgastric and the deep transgastric view. So we can start with the mid-esophageal 5-chamber view. As the transducer probe is inserted from the incisor teeth to around 20 to 30 centimeter, then it initially we can see there is a 5-chamber view. In the 5-chamber view, you can see there is all 4 chambers and along with the LVOT and the aorta. So starting from the left atrium, left ventricle, right atrium, right ventricle, and there is a LVOT, left ventricular outflow tract, and there is a aorta, and there is a anterior and mitral leaflet is there. So this here it is utilized for the some pathological condition like in the HOCM for the septal measurement or the aortic regurgitation or for the turbulent flow, so in the color Doppler. So these are the mid-esophageal 5-chamber view. So from here slightly advance toward the esophagus, slightly advanced, then it comes to the mid-esophageal 4-chamber view. So in this mid-esophageal 4-chamber view, we can see there is clearly we can visualize the whole 4 view chambers in the 0-degree position. So here we can see classically ventricular function, then mitral valve, any mitral valve or the tricuspid valve disease, interatrial septum, interventricular septum. If there any pathological condition like a pericardial effusion or the mitral regurgitation, tricuspid regurgitation or the atrial septal defect. So we can visualize basic on this mid-esophageal 4-chamber view. So here we can see there is all 4 view. We can clearly visualize left atrium, left ventricle, then mitral valve in the from the right to left, A1, P2, A2 and A3 callups are seen. Then right atrium, right ventricle, interventricular septum, right free wall and anterior wall, and then posterior tricuspid valve, and there is a septal tricuspid leaflet. So from that, this 4-chamber view, we have to focus on the left sided and then try to rotate toward the anti-clockwise position, and we can get a mid-esophageal commissural view. So towards the 45 to 50 degree, we can see classically commissural. So here we can see there is a P1, A2 and P3. So P1 scallop is there, A2 is commissioner is there, and the P3 scallop is there. So they are classically for the mitral valve disease or the left ventricular function and the left atrial pathology. Here we can see there is a left atrial appendage also we can see. So if there is any appendage clot or any appendage closure procedure, we can see this mid-esophageal commissural view. So next is from that we have to focus on the 2-chamber view. So slightly rotate towards the 90 degree. So here we can see there is a 45 to 50 degree we can commissural view, then turn towards the 90 degree. So it is from bicommissural view to get into the 2-chamber view. So in that we classically see that there is a left atrium, left ventricles. So here we can see, use for this view for the left atrial mass or any thrombus or left ventricular size and function, mitral valve function, and there is any mitral annulus measurement for the mitral valve surgery. So here we can see there is a LA-LV inferior wall and the anterior wall, and there is from A2 scallop to the A1, A2 scallop, A3 and P3 scallop are seen. So from that that 2-chamber view, we have to change the axis from the 90 degree to the around 130 to 145 degree, then we can get this mid-esophageal long axis view. So here in the long axis view, we are using for this main function for the left ventricular function. Then this LV inflow and outflow view we can clearly visualize with the mid-esophageal long axis view. So here we can see there is a left atrium, aorta, LVOT, and then left ventricular function. So here we can see for the any aortic valve disease like aortic regurgitation or the aortic dissection or the interventricular septum or any cardiac error or or there is anteroseptal or the inferolateral wall motion abnormality in myocardial infarction. So here we can as a labeling that LA, LV, LVOT, then aorta, and then RV and inferolateral and the anteroseptal wall. And so here we can see there is a A2 and P2 scallop here clearly seen in the mid-esophageal long axis wound. So whenever the patient with the mitral valve prolapse or the mitral regurgitation clearly see from the mid-esophageal long axis view, there is a aortic A2 scallop, A2 and P2 scallop of the mitral valve clearly seen, and then we can see there is a prolapse, or these are used this view during the mitral clip. So from that we can slightly withdraw this probe toward the upper esophagus, slightly upper esophagus, and here we can see there is a bicaval view. So here in the 90 degree, around 90 to 95 degree, we can see there is a inferior vena cava and superior vena cava. That's why we called as a bicaval view. So this view is classically used for the atrial septum defect. So in the atrial septum, here we can see there is an intact of the interventricular septum, but in the case of the secundum ASD or the sinus venosus ASD, we clearly see the defect in the interatrial septum at the level of the fossa ovalis or the secundum, or during the crista terminalis. If there is absent, then we can see there is a sinus venosus type of ASD. Then another is a atrial pathology or PFO. Then if there during the any ICU or critical care procedure like lines or central venous line or the wires or the venous cannula like SVC or IVC cannula, we can clearly visualize with this bicaval view. So here we can see there is left atrium, interatrial septums, then SVC, superior vena cava, inferior vena cava, and there is a eustachian valve, there is crista terminalis and the right atrium. So again, when you rotate the probe around 30 degree, from the 0 degree to the 30 degree, we can see aortic valve short axis view. So in the mid-esophageal short axis view, we can clearly see there is aortic valve disease, then here atrial septal defect, left atrial size, or the coronary artery pathologies. So here we can see there is this view again helps in the bedside patient of the aortic valve agitation from the non-coronary right coronary cuffs, non-coronary cuffs and left coronary cuffs. So right coronary cuffs are present towards the RV, and then non-coronary cuffs towards the present over the RA, and then left coronary cuffs. So here we can see there is a right coronary cuffs as present toward the RVOT. So in the transesophageal echo, whenever there is a confusing regarding this coronary cuffs, whenever the right ventricular outflow tract is there is a right coronary cuff is present, and towards the RA side is a non-coronary cuffs, and towards the LA it is a left coronary cuffs. So here in the aortic view short axis, we can clearly visualize that is a vegetation attached to the left coronary cuffs. Then from upper esophagus slightly turn the degree towards the 30 to short axis view to the long axis up to the 130. This classically used for the left atrial appendage. So we can see these various types of morphology in the left atrial appendage, and then any pathology like left atrial thrombus or the left atrial appendage mass, anything we can see. So this view is used for specifically left atrial appendage. So before the balloon mitral percutaneous balloon mitral valvulotomy, we do a transesophageal echo to rule out specifically for the left atrial appendage clot. So before any percutaneous procedure in the BMV, we are used this transesophageal echo for specifically clot in the LA. So from here we can clearly see RA, RV, then aorta, and then aortic. If there is any aortic aneurysm or flow reversal, we can clearly see from this view from upper esophageal left atrial appendage view. So these are classically RA, RV, aorta, LA and left atrial appendage view. So here we can see there is a classical thrombus present in the left atrial appendage. So these are the relative absolute contraindication for the percutaneous balloon mitral valve commissurotomy. So from here mid right ventricular inflow and outflow portion. So in this view, so we have slightly rotated toward the right and clockwise direction this probe, and we classically see there is a RV inflow and outflow view. So RA, right atrium, right ventricular, in between there is a tricuspid valve, pulmonary valve and pulmonary artery. So anterior tricuspidal leaflet, posterior tricuspidal leaflet. So in the patient with the tricuspid regurgitation, we classically align this parallel parallel beam to the color Doppler. So we have exactly we can we get the measure regarding the tricuspid regurgitation. So from RV inflow, inflow like tricuspid regurgitation disease or any right ventricular function, then pulmonary valve disease, pulmonary dysplastic valve, or any pulmonary artery pathology, we can clearly visualize from the mid-esophageal right ventricular inflow and outflow views. So that turned electronically toward the 45 to 60 degree for we can get a inflow and outflow view. So from that we can go towards the slightly again back to the 0 degree, slightly up, withdraw the transesophageal echo catheter. So in this mid-esophageal ascending aorta short axis view, here we can see classically pulmonary artery, main pulmonary artery and its bifurcation towards the right main pulmonary artery, left pulmonary artery, and then main pulmonary artery. So here we can see this view is used for the main pulmonary artery, aorta, and superior vena cava. So here we can see if there is patient with the in critical care unit, patient with the in ICU setting, who patient is cannot move for the CT pulmonary angiography or whatever. So in this patient we can do a bedside transesophageal echo to visualize for the pulmonary embolism or the saddle pulmonary embolism in patient with the cardiogenic shock or the high risk thrombus burden in the pulmonary embolism. So in this view we can classically see in the ascending aortic short axis view there is thrombus burden present in the main pulmonary artery or the saddle thrombus. So here we can see there is ascending aorta, superior vena cava, right pulmonary, left pulmonary artery, and then pulmonary artery and pulmonary valve. So here we can turn this turn the probe towards the 90 degree and we get a mid-esophageal ascending aorta long axis view. Here in the long axis view we can see classically ascending aorta. So this procedure is specifically for the critically ill patient who are presented with the cardiogenic shock or acute aortic dissection or the aortic aneurysm or severe aortic regurgitation region to rule out the pathology for the aortic root or the ascending aorta. Then we go for the then turn the probe exactly perpendicular to the 0 degree till the descending aorta is we will get a short axis of the descending aorta. So from the above, from advancing to withdraw, we see there is a classical whole descending aorta we can visualize in this view, in the short axis view. So in the aortic dissection or in the distal thoracic aorta, descending thoracic aorta, we classically seen if there is any aortic dissection, aortic aneurysm or the any other pathology. Another thing is we can see there is a color Doppler putting, that is flow reversal in the aortic regurgitation or the IBP or percutaneous bypass wire position or the left pleural effusion or the any atherosclerotic valve disease. So here we can classically see there is a true lumen and the false lumen in the aortic dissection. Then move towards the descending aorta towards the long axis view. So this plane is moving from the short axis to the slightly towards the 90 to 100 degree. We can see moving the probe towards the 90 to 100, and we can see there is a descending aorta long axis view. So here we use this for the aortic dissection or any aortic aneurysm or aortic regurgitation for the color flow reversal, and then intra-aortic balloon pulsation position. Now move towards the transgastric short axis view. So try to advance this probe, advance the probe towards the more inferior, more towards the 40 or 60, 40 to 45 or 50 centimeters inside the deep gastric, and then towards the fundus. But in between the fundus and the cardiac structure there is some structure are present. So at this time try to anteriorly flex this transesophageal echo probe, so we can clearly see there is a transgastric short axis view. So here we can see there is a left ventricular both the papillary muscles, then lateral anterior wall, inferior wall, lateral anteroseptal and inferoseptal wall. Here we can classically see there is anterior left ventricular wall, inferior left ventricular wall, lateral, then anteroseptal, inferoseptal, and then papillary muscles. Here we can see this is used for the transgastric short axis view for the eyeballing ejection fraction. Here towards the left side we can see there is a normal ejection fraction, and we can see there is a kissing papillary muscles. These are kissing papillary muscles usually used for the severely dehydrated or the volume depleted status. And here the right side we can see there is severe global reduced ejection fraction, left ventricular ejection fraction. So we can utilize this view for the calculating the ejection fraction. Now move toward the more apically and then transgastric apical short axis view to see for the anterior or inferior or the septal on the lateral wall of the apical short axis view. So in the interventricular septum mosum, or there is a left anterior descending artery myocardial infarction, where we can see there is aneurysmal apex. Now move toward the long axis view. From that we have to move deep towards the transgastric and exact perpendicular to this view. So we can see there is LA, LV, aorta, and then LV, OTO, and then RA, RV. So this view is basically for used for the any prosthetic valve or leak from the prosthetic aortic valve or the aortic valve gradient, and especially spectacle Doppler. So from this view there is a perpendicular beam is aligned. So this view is specifically used for the aortic valve gradient, because it is exactly perpendicular to the plane of the color Doppler, and LVOT gradient measuring with this view, deep transgastric view. Now these are the basal short axis view. In the basal short axis view we can see there is antero mitral leaflet, posterior mitral leaflet, then right ventricular, and this view for use for the ventricular septal defect, mitral valve planimetry area, and then left ventricular size and the function. Now these are the transgastric two chamber view. So this two chamber view we can see there is an anterior wall, inferior wall, posteromedial papillary muscles, anteromedial papillary muscles, mitral valve leaflet, posteromedial mitral valve leaflet, and antero mitral valve leaflet. This two chamber, this used for the left ventricular function and mitral valvular subvalvular pathology. We can see during the rheumatic mitral valve disease or the mitral regurgitation or any condition which affect the subvalvular pathology. So these are from this view we can turn toward the right side, then we form a right RV or RV, right inflow view. So in this view we can see there is a RA, RV and tricuspid valve. So we can use this for the right ventricular function, tricuspid valve disease, or tricuspid valve subvalvular apparatus pathology, or any tricuspid valve leaflet pathology for the tricuspid regurgitation or any reason for the vegetation or prolapse. Then move toward the left side, we can see there is a transgastric long axis view. So here we can see in the long axis view we can see there is a LV outflow tract. So in the LV, OT, and then aorta, and then pulmonary valve, and then ascending aorta. So here we can see transgastric long axis view for the LVOT or the aortic disease. Or here we can see there is a left ventricular septal systolic motion, aortic valves, and the septal and the color Doppler, and then LVOT assessment. So then slightly withdraw this probe toward the upper esophagus, toward the aortic arch long axis view. We can see classically as the ascending aorta and its branches. So aortic pathology like ascending aortic dissection or the aortic aneurysm or the in aortic regurgitation, we can see there is a color flow reversal we can see in this short axis view. Now this upper esophageal aortic arch short axis view. So whenever there is a RVOT or the main pulmonary artery is open, we can see there is a left subclavian vein is left subclavian arteries arising from the aorta. So first branch we can see from left side, the left subclavian arteries branch from the aorta, we can see via the RVOT or the main pulmonary artery in the short axis view. Then moves toward the here the aortic arch pathology, any pulmonary valve or the patent ductus arteriosus we can see in the aortic arch short axis view. Then again we can see there is moved the probe toward the perpendicular to orthogonal view. So we can see there is a inferior vena cava in the deep IVC view. From here we can visualize for the tricuspid regurgitation or any mass, tumor, thrombus, or inferior vena cava wire or cannula, or inferior vena cava respiratory any variation. So we can utilize this view for the various procedure. So thank you very much for your kind attention.